at the University of California, Davis, and the co-director at the Cost of Care Incorporated. She'll lead us through a presentation on the Affordability Accelerator Framework, which is a roadmap of opportunities to reduce out-of-pocket healthcare costs across the continuum of care. There will certainly be time for discussion and Q&A at the second half of this hour. So I do highly encourage you to put your questions in chat. When we get to that part of the presentation, or this hour, I should say, we also encourage you to unmute yourself, introduce yourself, and ask your question directly. So for those of you who are unfamiliar, my name is Marie Hubbard. I'm a Senior Program Manager for the California Improvement Network, also known as CIN. CIN is a learning and action community that advances equitable healthcare experiences and outcomes for Californians. We do that through cross-sector connections, spreading good ideas, and implementing improvements. CIN is the program of the California Healthcare Foundation and managed by Health Force Center at UCSF. You can learn more about our organizations by visiting our websites. A few tips before we get started. You are all currently on mute until Dr. Gupta goes through her presentation. And then we highly encourage you to use chat and unmute yourself at the second half of the hour and engage in discussion. So with that, I'm excited to introduce Dr. Reshma Gupta and walk us through our conversation today.
Great. Well, thank you so much for the invitation to speak to you all. This is a passion area for me, so it's really an honor to be able to speak, and I feel very connected with this group and others who have really supported my project in the state and as part of the California Healthcare Foundation CHCF Fellowship, as well as a healthcare leader in California. So really thank everybody. But I want to really go into just starting off a little bit of background about what motivated me to do this personally in the first place, and then I'll get into actually the data and all the things that are at the state and national level. But this actually is a really personal motivation. So a lot of this work is not part of my actually traditional day job, but something that I've really been invested in outside of that. And I think part of it is that there are not a lot of roles that focus on this specific issue that exist for me. And so being able to do this outside of that has been required. So just taking you back to 2005. So I have a very close friend who lived in Texas back in 2005 with her fiance, Andrew. They lived together. She was working in entertainment and he was in getting a PhD in robotics. Both of them had health insurance, she from her job and he from his school. But he started to get sick. He started losing weight and he was actually diagnosed with a really hard to treat cancer. It was a really large blow to both of them. They were in their 20s at the time with their whole, careers and ambitions ahead of them. As they were moving forward, they decided to still, even though he was sick, to get married. And his school insurance barely covered any of his bills. It was what now we call almost like a sham insurance, but a very, very basic coverage. In less than a month, he had essentially reached his prescription maximum that was covered. And as he got sicker, my friend had to quit her job to essentially help care for him. And very quickly, they met their lifetime limit. Collection agencies started coming, and they both had to move in with her parents to essentially care for him and to not have to pay the bills elsewhere in their life, giving up education, giving up housing, giving up the state that they were living in to go back home. 3 months later, he passed away. And so it's a story that I think really hit me, not only as a close friend, but this commitment to see what does our health system do to help patients that are in this scenario. I think all of us, no matter if we're in the system, around the system, outside of the system, have family members or ourselves where we seek care. And we're surprised, like, wait, there's another bill that came in the mail, and why is that? And I don't often know the cost of the services that I get. So this is really, over the last decade, helped me to really focus on prioritizing advocating in this space and thinking about healthcare affordability specifically with a forgotten lens of our patient out-of-pocket costs. So I'll jump ahead to the next slide. So I wanted to share with you a little bit about, across the country, what patients are experiencing. And especially I updated these slides and actually pulled some data just from the 2024 recent surveys that have been done around patient affordability. But less than 20% of households report that they know the cost of healthcare services before receiving them, even though 95% say they want this transparency and they want to have conversations about it. So an enormous gap, right? More than 50% of households worry about affordability, and almost 2/3 say that they worry about being able to afford unexpected medical bills. Almost 40% delay care due to costs, and 30% of those say that those are for serious conditions. So really affecting even as clinical care teams, healthcare executives, policymakers, other of our patients really getting needed care as well. Unexpected costs, as we know, are affected with many other things. I often think about these healthcare costs in a sense is almost a social need when it comes to reaching healthcare outcomes. It affects the experience, but even the ability to, receive treatment and access in itself, as well as trust. And so often care team members, health systems, others are often ill-equipped to have these conversations, but not only that, in addition to know that the data is transparent and even know where to go to help patients if they're struggling with this. So I actually did a survey. This is something that's not required by any, external agency or reporting agency or anything within our own health system, surveying patients around social needs. And I included the cost of healthcare as one of them, which is often not part of what we often do. And it was by far the number one concern that we often don't even survey amongst our patients. Next slide. So this is actually some data coming specifically from Medicare that my team actually helped analyze, like the raw data deep into the claims data of Medicare. And what we looked at was healthcare expenditures, both by how we often look at it as a health system for total expenditures, and then also out-of-pocket costs. And I think where the opportunities are, where we in the world of value-based care often look at where are there true opportunities for improvement or change, really shocked me in a lot of ways, because it wasn't the things that we normally talk about when we're thinking about the beneficiary being the health system or the payer. So a lot of times we will talk about hospital costs, healthcare utilization from hospitalizations, ED visits, or the clinical services, and then pharmaceuticals come up. But when you look at it for out-of-pocket costs, it's not completely, but a little bit of the reverse. And it makes sense because some of it is getting reimbursed by insurance and whatnot. But the biggest drivers often are non-durable medical equipment or durable medical equipment. Pharmaceuticals come up again, but also a spattering of other things like dental care. And not all of those have had the same attention that we put on when we're looking at our healthcare costs as health systems. And so the question is, have we really missed the opportunities to advocate for our patients? And the thinking that if we address the system of costs for the health system, that somehow that's going to trickle down to patients is not really true. And so we have lacked a roadmap to really think about how we address that. And wanting to advocate in this space, I realized that's actually the point that we have to start. What are the ideas of even how to get started? And that's what I started jumping into. Next slide. So I went back and really tried to think about what drives this. What's that context of where the rubber meets the road, in a sense? And there's a number of factors and context I want to mention. And some of those are individual factors. So social influencers of health, for example, and kind of where patients are coming from and the resources they have, that financial vulnerability that each patient comes in with. Does their family have a whole bunch of savings? They have an extra pocketbook because of their family or a sister or someone else they can go to if trouble were to happen, or do they really not? The buck ends with them. Other factors like insurance plan factors, so having high deductible plans, for example, is one we often will talk about. And then those relationships between the healthcare system and the payer to be able to work through billing issues, right? And especially if there's a gap there. And then this all is in a context of our communities, our state, our national policies around Medicaid expansion, for example, for certain patients, also around cost shifting, bans for cost shifting, price negotiations, that some individuals have the benefit of having those already in place, and some, depending where we live in the country, may not. And then the buck ends with them again. all of this context comes and hits the clinical event. You know, a patient, for example, who has one catastrophic event, as we say, but, you know, a bad car accident with a bunch of injuries and surgeries that were unexpected all at one time, versus even chronic conditions that go over decades, right? That kind of tear away at their pocketbook day after day. And so all of this is really complicated to think about, and we haven't had a framework for that. Next slide. So one of the things that I started doing is actually working with a group called Cost of Care that was mentioned in my bio, that actually brings together folks that are interested in advocating specifically around this issue. And what we decided to do was host something called an Affordability Accelerator. And we said we need to bring people who often live in very siloed worlds together, not only to hear each other, but to problem solve together. Because one of the things I realize is when we talk about these issues, we often talk in our own bubbles and we don't speak each other's language. So sometimes the billing expert is not talking to the clinicians who are not talking to, you know, the operations team that work through the workflows, that aren't talking to the patient navigator, and then forget the patient and caregivers themselves or families. And so what we did is we brought people together from different parts of the country, different population types, healthcare systems, and also payment models that are familiar with different models and payer mixes. And we broke them into small groups that each had patients, navigators, social workers, and billing experts, and brought that direct expertise into the room to have conversations to really brainstorm what needs to be done and what could be done. Next slide. So the focus of this really had two major parts, and it's ongoing to date, which I will update you about as well. But one was some national convenings where we actually brought these groups together as almost the first step or the first phase to really create a roadmap of where there's opportunities, thinking about this in a more holistic perspective. And we took the perspective specifically of what health systems can do. And part of this was patient-driven, that this was a focus point of intervention that they really wanted us to address, because a lot of conversation is around the payers themselves. And I think that's a major component, but this was a new lens we wanted to add to the discussion. And then how we actually take action. And so there's efforts to try to promote health systems to implement programs that have been guided by patients themselves to address these issues. And then also policies, because this work is so green in the sense of advocacy in the space, to think about what policies need to be protecting patients and also health systems to keep accountable to that patient experience and the out-of-pocket costs related to that. Next slide. So our focus initially was a few things. One was finding these strategies to align the clinical and financial decision-making through patient experiences, and really thinking through care pathways in an operational and a health system perspective. Example being, someone is screening for breast cancer, they get breast cancer, they go through treatment, they go through remission, there's maintenance therapy. So through that entire process from screening all the way through, identifying where those cracks are, where we're not just thinking about the clinical pathway and experience, but the financial experience at every step and every risk point where the rubber meets the road. Identifying, like I said, those friction points. And we actually outlined it by almost how patients get bills, to be honest, but indirect costs that they may face. So these are things like parking, right? Social type things like getting childcare, facility fees, professional fees, pharmacy fees, and telling us through those patient stories. And we initially started focusing on Medicare and commercial coverage opportunities, knowing that there's a lot more opportunity, I'll say, in those areas, specifically when it comes to patient billing. And then we were asked, the members were actually asked to work through, from a health system perspective, what would a moonshot vision be? There's a lot of barriers to say, well, we could never do that, so we're not even going to throw out an idea. But to really say, what could we do? What should we do? And almost becoming a North Star. Next slide. So I want to go back to make this a little bit more concrete for folks. The breast cancer story was actually one of the stories that we use. We use some real stories to have these folks come together and walk through each phase of kind of clinical care delivery to point out where financial friction points and bills would come, and where things are not aligned and where things could be done differently. So if we go back to the story of my friend's husband, Andrew, who had that kind of poor insurance. There's various ideas that really came out of, his story. And I think part of it is with these unexpected costs that often leave people with that risk of financial harm. They also lose that trust in the system and are ill-equipped to deal with it, from price transparency to infrastructure to the health systems have to identify patients with financial risk, and also our staff trained in those cost conversations. So even through his story, he didn't know any of the prices really of his care to help him make decisions and find lower cost alternatives. There really wasn't anyone there to counsel him, to answer questions and proactively plan for his life savings and other decisions in his life. And when they called, billing often didn't answer questions where no one in the care team was really owning this as part of his care. So there's a lot of finger pointing in a sense to talk to various people without answers. So he actually underwent in his clinical care imaging and labs obtained at a hospital site. He was referred to an out-of-network surgical oncologist in his care pathway, surgery and infusions at a hospital operating facility, adjuvant IV chemotherapy that he had to take time off work, and some of those other things I mentioned around parking. And then afterwards, daily pills, medications with side effects, and other kind of therapy that was required. So if we jump to the next slide, I really want to walk you through concretely what, opportunities were identified for him, to make it easier to start thinking about where we can intervene. And one of those key points on the bottom left was a theme that came out of these discussions around empowering patients and building the health system infrastructure to support the work and looking at key opportunities for those financial friction points. So really being able to advocate for patients, advocating for themselves in a sense. We next walk up this road as an opportunity of reducing indirect costs. So again, these are kind of that cost directly for the patients is actually how our patients wanted us to term that concept, but it's that parking and transportation and childcare and those things we don't often measure, but are so important for them. So having advance notice could have allowed, for example, time planning to take time off work to do certain chemotherapies, to plan for transportation, parking, working with other schedules, right, to help accommodate if there's some roadmap, even from a clinical sense, to move from. The other was reducing facility fees. So by not using or by using lower cost sites of care, such as high quality lower sites of care for Andrew's surgery, that could have been an opportunity, right, where there could have been some discussion point in making those decisions. The third there is reducing professional fees. So looking again at quality, cost-effective referrals, such as specialists, can be an opportunity when we think about in-network, out-of-network referrals. And there's lots of logistic complications around that one, but potential opportunities as that North Star. And then reducing unnecessary pharmaceutical costs. There's been a lot more activity in the last few years around, but using lower cost alternatives, so for example, for Andrew's side effects or for the infusions, doing them at home, for example, as a different site of care related to that. All of these are very concrete things that were not done and that could have been opportunities. So imagine what it could have been for him if some of this was in place. Next slide. So from this effort, we sat down and actually created, you'll see the circle that was earlier in the slide as well, some of these key opportunities, right, between, creating opportunities for the patients, caregivers, communities themselves to help them be empowered and advocate, policy reforms around patient protections or even price limits, and then health system actions. And they really fell into these 4 domains that came out of it. There's almost 45 ideas that came out of this convening. So I wasn't going to put them all on a slide, but I wanted to share this QR code because it'll actually take you to the paper that we published that came out of this. And there's a few tables in there that really walk through where some of these domains are. And for each one of those types of bills, those opportunities through the roadmap, what are some of the very concrete ideas that came out? And it's really exciting to see these ideas come together and kind of where it's gone in this next phase. Next slide. So I want to summarize just a few key domains that is popping up on the slide in a second. But few key domains where we really see there being some additional opportunities. And as that's coming up, I'll kind of just run through them briefly. But one of them really was around expanding measurement. So expanding the measurement of our ability to think of delaying, our thinking about billing patients, for example. So being able to make sure that we are getting an appropriate assessment of how much out-of-pocket costs are getting shifted to patients without really knowing that. It's really hard for health systems to intervene and creating infrastructure to support patients as a whole, as issues come up one by one. Another major area that was identified was around bill mediation, regulations, and other patient protections. And so there's been legislation in California that's been addressing this for some time, but not all states have that. And I think there's a lot more that came out, especially when we talk about rural areas where, for example, the specialists that they have to go to are limited, and there's some limitations, but the costs are high and what that means to patients to protect them. There's quite a few items that address empowering patients through transparency and education. So even if either care is expected or unexpected, there's a certain amount of counseling and financial navigation that can help patients. And so even if there's an emergency situation and the care had to be given, we know there's bills coming, and there's still the ability before those bills hit our patients to be able to give them those resources to say, hey, let's talk about what's out in the community and what could help you, because we know what is coming. And then the other piece around health system programming. So this comes into what I was mentioning around financial navigation being a really clear opportunity to address some of those social needs, but also those resources. And then the final large domain was around community programs and partnerships. There's various community programs to help patients think through, especially in the cancer space, but also in some others around transplantation. But that model could really be used to help guide patients that talk with them before care happens, during it, and after. And one really unique thing that I think came out of this is the patients that we had talked to in this group were very concerned about sometimes financial navigation can have bias. Sending a patient to another facility that's less expensive may go against the revenue of their own institution where they're being seen. And so almost having some of these groups, that financial navigation also coming from the community where that bias is a little bit taken away, was a great way for them to feel like they were getting the best advice from everywhere that they went. But the biggest lesson learned is that all of these ideas, all of this right now is all set on the patient who's already sick and already struggling to help navigate. And so having a roadmap like this can really help. I wanted to share one more thing, and then we can kind of maybe open up for questions and whatnot. So from this work and from that paper, we were actually invited in 2 different venues to present and to help kind of guide strategy. So one was with the Center for Medicare and Medicaid Innovation, so the CMS Innovation Center has 5 kind of key pillars that they focus on, and one is around affordability. And if you read through what it was, let's say 4 years ago or so, it had this component of affordability without actually calling out patient out-of-pocket costs. And so we were actually invited to present this structure and this framework, and speaking with their chief strategy officer was able to actually add in language around patient out-of-pocket costs. And so there's parallel efforts focusing around reducing pharmaceutical costs and some of the negotiations and things like that that Medicare is doing now. That's the news the last few years. But to be able to expand that and even go beyond that in different ways, I think is where there's a lot of interest to see where there's opportunity to align. And then the other is, I think from some of this work, even for myself, I've been able to intersect with our new Office of Healthcare Affordability for the state of California, which has been a great opportunity. And one area that I think there's been a number of strong advocates in the state about is, what about the patient part of that? As we're thinking about affordability, what about the patient outcome? How are we measuring that? And let's push ourselves to look at the data and, bring that together so we can leverage that learning to then aggressively do all the quality improvement efforts we do on all our other outcomes in the same way. So lots more to happen. I think there's so much more on the implementation side. I'm very happy to take questions and to brainstorm, as this will be another decade of work, I'm sure. But I really appreciate the ability to share this work and this topic with everybody.
Great. Thank you so much, Dr. Gupta. I encourage folks, if you have any questions, please feel free to put them in chat or raise your hand. We would love to have a discussion too and kind of hear your thoughts and brainstorm ideas. Yeah.
Thank you, Dr. Gupta. This is very interesting and very, very helpful. My name is Huang Lu. I'm the health officer for Yuba County and Sutter County, and also a fellow CHCF cohort 21. And this is really exciting. I have to admit, I have not read your roadmap paper, so if some of my questions are addressed in the paper, my apologies. But it would be really helpful to hear from you. What are your thoughts on near-term solution, short-term solution, and long-term solution? Because essentially, as a health officer, and we just completed our CHA chip, and one of the biggest call out is healthcare access, but it's not just about insurance, as we all know. It's like, can you even get in to see the doctor? And are you afraid to see the doctor because of these out-of-pocket costs that we hear all the time? What are things that you recommend we partner with you on near-term and short-term solutions now?
Yeah, that's such a good question. Thank you for that. Really thoughtful as well. The paper kind of addresses it, but I feel like I can reorganize some of the information too to kind of answer your question. So I mentioned what some of those key domains are, and then each one of them has, a number of kind of sub ideas that are very concrete, tangible things. The biggest barrier, just to cut to the chase, is data, actually, because our ability to really understand it across our population of where there's opportunities, right, and where our structures, create cracks for our patients is unknown unless we're able to look at it at a broader level. Like any quality improvement initiative, until we have the data, and then you can say, but what populations affected the most and how, and in what situation, and what's their story? It's hard to really intervene. And so one thing I would say that is maybe medium to long term, and because of some of the work that the state is doing here, it's not long term, it's maybe medium term for me because it's started already, but is to really activate the state doing some of that data aggregation, because it's so much work to do across every single county, every single, agency. And so having that help, I think, is huge. In parallel to that, though, I think there are some now opportunities, and I'll mention a couple, and they kind of go in two pieces. So one is around patient education, workflows, communication. We know that there are certain areas within our medical center where patients tend to are going to get big bills for things, right? And if even looking at and everyone has a different payer mix in terms of what they see, but if it's different commercial plans or Medicare or whatnot, there are certain things that our finance departments know that there's a higher risk of bills coming towards patients. So one is that what patients have been asking for is almost like a with getting their insurance number and all of those things, if it's something that's in the hospital and it's more acute care, before leaving, being able to get some counseling to say that, do you have screening, right? Like, do you have concerns about the bills that might be associated with this? And if you do, here are some resources that could help. And so those are some real things that I think are not huge lifts to incorporate into workflows, so that at least the anticipatory guidance and the empowerment to connect to them are there. And then I think for chronic conditions, it's a little bit easier because there's multiple points in the care of a patient to intervene. But we know when someone's diagnosed with a chronic condition, the type of medications, the type of timeline they're going to get. And for some of them, making sure that that's there. Oftentimes our pharmacists, especially when it comes to medications, will do this. This is kind of a structure that we already have in a lot of our systems, but to use that similar structure and workflows for some of these other areas, right? When it comes to even imaging and whatnot, like for breast cancer, there's some standard imaging and workup that they do. I think those are actually closer to the near to medium term opportunities that there are. The other one that I would say is near term is, Many of our medical centers actually go after patients through claims and lawsuits to bring the money back. And so really having transparency about how often our medical centers are actually taking patients to court for these medical bills versus going on the other end of approaching it in terms of how can we help them, right, to meet those. That's a big issue. And I think California has been a little bit better because of some of the regulations around that and some patient protections, but not, like I said, everywhere in the country has those. And so it definitely, I'm sure you see media reports that come up every so often of some health system getting in the media because they're have sued patients over some of, not being able to pay the bill. So that's where I would start.
Yeah, no, that's very helpful. Have you been able to share this wonderful research with, say, the CMA and the CHA, so California Medical Association and the California Hospital Association too?
Not all of them, no. Yeah. Feel free if there's anyone on the call who's interested. We are happy to get the word out more around where some of these opportunities fit. And to do it in a way, my day job is actually in population health and accountable care in a health system. And so I definitely am working with the payers and know the lift that this would take from an operational standpoint. So I sit on both sides of this issue. And I think there are ways that are, like you said, lower lift and things that would require more support or policy support for the health system to execute on protecting patients in this way. But there are opportunities now. Thank you.
Thank you, Fawn. All right, we have a few questions in the chat. Two from Vanessa, really focused on the resources, community resources that are offered to families, both for financial support and education. If you could speak a little bit to that.
Yeah, so this is also kind of a growing field, I think, but there are a number, and this always depends on, your local community to kind of name specific groups, but there are a number of groups out there that focus more so on, advocacy around social needs. And I think that this component around financial security, financial health often comes into that. Health Leads obviously is a name that a lot of folks will know, and that has branches all over the place. One of the groups that we integrated into our sessions that we had was actually a group called Family Reach. Now, there's a lot more in the cancer world, like the research and the advocacy around the cost for cancer care for obvious reasons of, a lot of the medications are very high costs. There's so much that goes into the cost for patients that space is a little bit more advanced, but I think those models can also be adapted for other conditions, but it's a growing field. So Family Reach is one that's a national organization, but they have so many resources that come to and practices of how they approach patients, how they communicate it, cancer specific, but they almost have like these binders that they meet with patients about to talk them through. And so that they even feel prepared to have conversations with their care teams to advocate for themselves and coach them in that way. And this is a group that's actually out of the health system, right? It's one of those community kind of supports that they can connect to. So those are just a couple names that come to mind that are more robust, but there are others.
Thank you.
Family Reach, that's right. And if you look at the paper, if you're able to get a hold of it, one of the things that we did is for each of the different domains of opportunity, we actually asked Family Reach, which is a community-based organization, and House Medicine, which is actually like a health delivery group, talk about their financial navigation services across each of those domains and how they look different coming from the community versus coming from within a health delivery group. And so that's actually a really, really interesting way to pair that up. So I would recommend taking a look at both of those. Yeah, thank you, Marie, for sharing those links.
All right, so Peg has a question just around, does the data suggest that cancer patients experience the highest out-of-pocket costs?
If you look at it by relatively common conditions, medical conditions, yes, that is one that has a long history of that. And I think over time, insurance coverage and other things have made it easier, especially in certain states. There's some rare diseases that if you look at it by that are even higher, but they're so rare that they don't come up as often. So I'd put those in the same camp. The other way to look at it is kind of back to one of my earlier slides about the hexagons and all the different kind of factors to include, is just the patient's payer plan, right? So you could have a very common condition that you think, well, everyone covers this. But if you have that super high deductible and it's you and yourself have no backup money, no assets, none of that, you're going to get in trouble as an individual patient. So yeah, I think from the research, cancer and the literature and the groups, they're much more advanced to think about advocating in this area that could be models for others. But it's not a one for one, and that patients fall through the cracks all over the place, depending on all these other factors.
What other questions do folks have? Yes, Rena.
Hi. Yeah, so I just wanted to first say thank you for the presentation and the paper, which I'm looking forward to reviewing. It's amazing, and I'm so glad that you're already connected with CMMI and OCHA, those different offices. I work for a large health system as well in pop health, but focused on Medicaid strategy. And I can just see so many parallels to the Medicaid population, and was wondering if you all had plans to sort of expand beyond Medicare, and also beyond, maybe some of these diagnoses and things to look at other areas as well.
Yeah, I think we have a lot of interest to kind of keep expanding. It's almost like it's such a new field in a sense that I mean, if you look, there's nearly nothing written about this in the space outside of cancer care and outside of pharmaceuticals. And like our state's doing a lot around medications that kind of go more broadly, but often in diabetes medicines or some of these new ones coming out. And so there's, how to think about some of these care pathways, I think is a great approach to get our minds around it. And that's how we approached doing this work, is that there's so many opportunities, it's almost overwhelming. You could drown with the weight of developing a program around it and without a lot out there. So yeah, so we are really excited to think about chronic conditions, and then some of these acute episodes of care that are really like catastrophic events is right, like what they call it through the payer world, but that how they're different and how we need to think about that care pathway from before it happens all the way through, that continuum of care. And one of the things I think that we realized makes it very concrete is when you talk about it in those different phases of care, you can break it out. So we could do the same thing for kidney disease. I think now a lot of those patients, especially if they're adults, will qualify for additional insurance, but that's part of financial navigation. Or for transplantation, another thing that's very expensive, but insurance, once you get into the right plan, will actually cover a lot. So part of that is actually getting the folks into the right plans. I think in the Medicaid space specifically, there's a little bit more complexity of also where patients go and where they stay. Because the population in itself sometimes moves around a little bit more. And so I think that's an area we would love to partner with and actually kind of think through, but we haven't yet done that in as much depth as we have with the other ones.
Okay. Yeah, that's really helpful. And using the kind of that format of the care pathways would probably apply to, no matter what sort of line of business you're looking at. So appreciate that.
Yeah. And I can share a little bit with kind of what we're talking about with the pathway. So we almost had it's a little bit different for the catastrophic events, but for chronic conditions, there's like a screening and diagnostic phase. There's an intervention and treatment phase. And then there's a post-treatment or recovery phase. And then using the words of cancer, survivorship, or kind of that maintenance phase. And for each one of them, for there is a semi roadmap of what the clinical care might look like that a patient may receive for an evaluation. And so taking chronic kidney disease, going from kind of screening to all the way through maybe needing transplantation or dialysis. It's basically walking through each one of those phases and then saying, to get that care, what is the financial story of where some of those bills would come from, and then what is the financial counseling that could, or even education or anticipatory guidance that could be provided for each one of those. And so breaking it up in that way makes it a lot more concrete to walk through, and made it much more fruitful to have discussions about it and create new pathways.
That makes sense.
Great. We have another question in the chat. So what notable changes have payers or issuers made to contribute to a solution to the cracks that patients with HDPs fall into?
Yeah, so we actually had a number of payers that were part of those work groups that we were talking about to kind of give their input into what we had. So there's pieces around this that I think depend a little bit around policies of the state as well, and kind of what protections there are. So there's a little bit of variation that's there. But one of the things I think that's been really helpful is that being payers specifically, having that relationship with the health systems, I think in terms of being able to negotiate when some of those catastrophic bills come up is one area where there's been a lot of payer alignment, because it's not the goal of the payer also to be ultimately getting patients in trouble and putting them into that situation where they, are having collections come after them. And so that negotiation, and I think part of that is the legislation that we have in the state, or even in other states, where that mediation that's now required with some of these surprise bills and kind of that whole area is an opportunity for collaborations with the payers. I think another area of collaboration with the payers is around and again, it's different if we're talking about Medicaid and Medicare, because those are through state and national government, but especially with commercial, which has been a little bit more Wild West in terms of what happens and how they each work. There's been certain payers, I think, especially that want to kind of come to the forefront, which is good for their own business, to build employers and build patients to say that we're going to help you, right? Make this affordable for you and get you high quality care that's cost effective. And so being able to say that, there's these alternative to how the plans, how the actual plans within the insurance are going to diversify and kind of be able to address some of those things. There's been some media around Blue Shield, specifically in a few different states, that have actually done quite a bit of work to have out-of-pocket cost transparency there for, like, for example, getting a CT scan at a certain place versus another place, and they try to providing that data. Right now, though, a lot of that still goes on the patient to kind of navigate that, and it's not always proactive. I think there's a lot of room in the payer space. Like our thing was focused on health systems specifically, because that's what the patients were asking us, but there could be an equal write-up in a sense for where there's those payer opportunities that we haven't done. Yeah.
Thank you so much, everyone, for the great discussion and the great questions. We have about 7 minutes left. If anyone has additional questions or reactions to our webinar today.
And I think I'm just reading through some of the comments. I think we will be sharing the recording of this, so folks will be able to get that. And I think there's probably a way for us to get through the firewall of NEGM Catalyst and be able to share that with folks as well.
Absolutely. I have a question. As you mentioned as you were talking too, like what's this work gonna look like in 10 years from now? This is not gonna stop today. So I'm curious, like, what are you most excited about as you think to 10 years from now and really this work's impact on the health ecosystem as a whole?
There's two areas that I'm really excited to go into kind of further. And they're on almost different spectrums. There's like the conversation that we've been having. So one is around actually making the concept of financial navigation a lot more robust. And I think finding some of these models, like for me, Family Reach was a big one, but there's other ones out there that when we say that we have financial navigation in a health system, it's usually getting people signed up for insurance. And maybe there's a few other questions that are asked, but that's it. And there's not necessarily a formal training that's required of that staff to do so much more. And so really bolstering financial navigation supports to do the kind of longitudinal financial navigation that's almost like a care management, right? That goes along with this to navigate the system. That model is so impactful, like when we talk to patients about that experience to really help them close their gaps and also feel supported in the experience. So I am really excited over the next 10 years for that. One thing is though, some of that stuff is really not reimbursed, right? And so how do health systems and others pay for that, right? Or how do patients pay for that and get those services? So some are, community groups that, have a way to do this without asking the patients to pay for it, but that's not a fully sustainable model. And so this is the other piece of it, the policy side. I think so much of this is so early that policy side to say, hey, this is a covered benefit to some level, or this is something that we're going to reimburse for to some level or rate at a broader level, even outside of cancer care, right? That's the thing that I think would be a huge opportunity. And then the other thing I'm really interested in is like different communities that sometimes are at higher risk. So some of the rural areas where the access issue makes them have to use certain specialists, for example, they don't have choice, to be able to find ways to create the choice, if that's through teleservices or how do you protect the patients in those areas, if they don't have those systems, and to think through some of the policy. So I think there are two very different ends of the spectrum, but I think both of them are really exciting opportunities to help our patients.
Great, thank you. And we have one more question in the chat. And Shelley, I noticed you took yourself off mute. Do you want to ask your question and introduce yourself?
Sure. I think I'm off mute. I don't really know if I'm on camera. Let's see. Let's say hi. Hi.
Hi.
Hi, Dr. Gupta. So thank you so much for the presentation. I really appreciate listening to all of the different aspects. I'm working on my MHA also, and so kind of digging deep in some of these areas of affordability and throughout our coursework. And I was just kind of curious, when you talked about price limits and things, were you talking about in the cost of obtaining those high deductible plans, or were you really meaning on the delivery of care side? And if so, like what sorts of, and your paper may say this already, but what sorts of price limits would you anticipate putting into play? Like, how would that go about? Would it be a stratified thing based on people's ability to pay? And so I'm just curious to hear your thoughts around that.
Yeah, that is a loaded question. And there's no actual clear best practice around this. So this is just me pontificating a little bit. But I think there's two pieces to that, just to create that clarity. From the slide that I had where there's two bars with different colors. And if we're talking about limits that affect an outcome of expenditures from a value-based care contracting side, or if we're talking about true out-of-pocket, which is I think what your question's about. So there is movement, right? And even and some of the state-based organizations now are looking at other states who've tried to bring down the total healthcare expenditures at an aggregate level for value-based care, for the costs and the spending that we have in healthcare outside of patient alone, although OCA now is trying to incorporate that as the data is going to come in to speak it from both languages, the patient and the other. But they can get their mind around, we can get our mind around where the data exists, and that is setting limits. And so there's other states like Massachusetts and others that have actually set kind of limits on spending, right, for overall care. So I think there's opportunity there, and there's some movement there already. The out-of-pocket side, the data limits us to have the exact same conversation yet to know where those opportunities are. But when we're talking about some of those things that came out of the paper for price limits, it is falling a little bit more into, I think, payer design or plan design. So it's not just it's not just deductibles, but it's co-insurance and co-payments and all the other components that go into that to come up with plans that are gonna have more protections for patients essentially. And if there is a little bit more risk with some of those plans, that communication, the transparency, the associated financial navigation and things like that that go with it as well. So absolutely there are some, and I think this is a little bit more on the payer side for payer products, in a sense of, you know, for certain services, you know, how much do they cover versus not cover, and, you know, what goes towards that deductible versus, you know, other things. And so that, I think that is a space that already exists and has a lot of opportunity for improvement. But the patient side might actually require some regulations of accountability both to the payer and the health systems. And that's something that's very uncomfortable, I think, for people to talk about, to say that there's regulations, but there are not many patient protections that exist right now. So
Yeah.
the
bills are crazy. I noticed even just getting a primary care bill for my own child, and I was like, what the heck? Like, I know what we paid, but when I saw the bill, it was thousands of dollars for like a visit. And I was pretty amazed.
shell shock, yeah. Understood.
Thank you.
Thank you so much. Thank you so much, Dr. Gupta, for spending the last hour with us and sharing with the network. I'm going to just launch a quick poll, and please respond. It helps us better understand and adapt our offerings to make them useful for all of you. But help me in thanking Dr. Gupta for being with us. I know we'll stay connected to this work, and thank you for all that you've done around this.
Great. Thank you so much. And thanks for such good questions too. Really, really great questions, and always happy to connect offline.